Okay, depending on your time zone, good morning, good afternoon, or good evening. Welcome to the first session of the ATS and Union joint webinar series, TB Elimination, Why Not Now? My name is Courtney Yuen. I'm an epidemiologist and an assistant professor in the Division of Global Health Equity at Harvard Medical School, and I'm joined by my co-chair, Rhea Lobo from Bolo, Didi. I'd like to thank the American Thoracic Society and the Union for their collaboration on today's webinar, as well as our distinguished panel of speakers for providing their insight into TB elimination. Before we begin, I have a few brief notes and reminders, just the housekeeping. So first, we've muted all the participants because there's a lot of you. Second, if you have a question, the way to submit that is on the questions feature, which is on the webinar platform. It should be on your control panel. Please note that this webinar is being recorded, and the recording will be made available to all the registrants, and the archived webinar will be posted on the ATS website, so you can share the link with your colleagues afterwards. The aim of today's webinar, which is the first in a series of 4, is to discuss the feasibility and the necessary steps for eliminating TB as outlined in the WHO End TB strategy. And with that, I'll turn things over to Rhea to introduce our speakers.
Thank you, Courtney. It's not every day that we have 2 women chairs from diverse backgrounds co-hosting an event, and I'm so happy to do this with you. Before introducing the speakers, I wanted to take this opportunity to thank both the American Thoracic Society and the Union for choosing a topic that keeps me, and I'm sure many of you, up at night. Is TB elimination even possible? I love how this is a question, because before COVID, I thought that it is. And now I find myself hoping against hope that it is possible, that it's still possible given the resources and energy that has gone into COVID. A bit of background, I am an extrapulmonary TB survivor and went through a series of misdiagnoses, 3 surgeries, was given the wrong meds, and ultimately the wrong dosage of meds, putting me at the risk of getting drug resistant. And I consider myself the lucky one, because in spite of being a part of a system that failed me, I somehow survived. And this comes from me, who is a person with privilege and access. And I shudder to think what people who don't have that go through. Speaking of privilege, I currently work in a job in global health communications in Copenhagen. For today's webinar, we are featuring 5 speakers and addressing a wide breadth of TB elimination topics. Our first presentation, modeling the impact of TB intervention strategies, will come from Dr. David Dowdy. Dr. Dowdy is an associate professor of epidemiology, medicine, and international health at Johns Hopkins University. Next, we'll hear about the model of how a high-incidence TB community became a low-incidence one from Dr. Paula Fujiwara. Dr. Fujiwara was, until March, the scientific director at the Union. After that, Dr. Amrita Daftary will discuss if stigma is holding back TB elimination efforts. Dr. Daftary is an assistant professor of global health at York University. Our fourth presentation will be What Does TB Elimination Look Like in 2021? Presented by Dr. Salmaan Keshavjee. Dr. Keshavjee is a professor of medicine and global health at Harvard Medical School. Lastly, we have another doctor, Dr. Priya Shetty, who will present on the role early career investigators can and will play in TB elimination. Dr. Shetty is an assistant professor of medicine at the University of California, San Francisco. Just to note, following all presentations, we will have a discussion among all presenters. Again, please submit any questions you may have through the chat function. We're ready to roll.
Hi, my name is David Dowdy. I'm an associate professor of epidemiology at the Johns Hopkins Bloomberg School of Public Health, and it's my pleasure today to speak on modeling the impact of TB intervention strategies as part of the joint ATS-IUATLD symposium on Is TB Elimination Possible? I want to start by giving a brief background on modeling of TB elimination. In 2013, Chris Dye and colleagues at the World Health Organization put together a simple model of the prospects for TB elimination. In this model, the authors suggested that it would be possible to eliminate TB, with elimination being defined as 1 case per million per year by 2050, with an aggressive combination of improved treatment, vaccine against infection, mitigation of risk factors, and treating latent TB in 14% of the population every year. The authors concluded that TB cannot be eliminated globally with the technology, procedures, and services we have today, but that the pathway to elimination is conceptually clear. This model formed part of the basis for the NTB strategy, which was launched by the World Health Organization and later affirmed by the World Health Assembly in its high-level meeting in 2018. In this strategy, the final indicators in 3035 are shown on the right-hand panel here, but targets by 2030 include an 80% drop in cases, a 90% drop in deaths, and 0 catastrophic costs due to TB. This model originally was accompanied by very simple projections of what it would take to reach these targets, which included a 10% per year decline in incidence by 2025, at which time it was assumed that the introduction of new tools could take place, creating an even further 17% per year decline over the subsequent 10 years. And with these drops in TB incidence, it was projected that the targets or the milestones of at 2030, including an 80% drop in incidence, could be achieved. Subsequent modeling, led by Ryan Hubin, but including 11 different mathematical models and published in the Lancet Global Health in 2016, suggested that a 50% reduction in TB incidence by 2025, which was the interim 2025 milestone, and still is not likely to be feasible without population-wide scale-up of case finding and preventive therapy. Shown in the figure here are the estimates of achievable incidence under what national TB programs in China, India, and South Africa thought would be realistic, but optimistic. You can see that in China, none of the models estimated that there would be an additional reduction of more than about 20% in TB incidence, even with a maximally effective strategy. In South Africa, some models did estimate a 50% reduction in TB incidence, but again, this was with a very aggressive strategy, including all of the potential interventions that NTP directors thought might be implementable over this time. So how are we doing so far in the face of these projections? As many of you know, and these are projections or estimates from the World Health Organization's global TB report this past year, incidence is falling at only about 2% per year. Mortality is falling by about 3.5% per year. Given that this is where we are as of 2018, 2019, and presumably 2020, though we don't have data from 2020 yet, meeting the targets of the NTB strategy would require a 4-fold and immediate acceleration in these declines. So a future 13% per year reduction in incidence and a 16% per year reduction in mortality. This would have to be implemented immediately and then sustained over the next 10 to 15 years. If we then further add in the impact of the COVID-19 pandemic, the situation looks even more challenging. Shown here is work that was done by Lucia Celloni, Helen Fu, and others at Imperial College London, where it was estimated that the COVID-19 pandemic could result in 1.2 million additional cases and 360,000 deaths in India alone. And this was from a relatively short suspension in services of only 3 months with a 10-month restoration to normal. We know already that this is not likely to be the case, especially with India experiencing a very intense pandemic even as we speak. It is worth noting that these effects are strongly dependent on the degree to which TB transmission is impacted by interventions against COVID-19, and it is possible that if these favorable impacts due to reduction in airborne transmission because people are wearing masks or distancing, etc., it's possible that in the long term, the COVID-19 pandemic may even have a positive impact on TB. However, in the short term, it's almost certain that that impact will be negative, driven primarily by people who have undiagnosed TB and are reluctant to seek care, either because they lack access or they're concerned about getting infected themselves if they go to the clinics, etc. So in a nutshell, the NTB targets will not be met. I feel confident in saying this, as I think it is highly unlikely that we are going to see a quadrupling in the reductions that we've seen so far in incidence and mortality over the next 10 years. However, I would posit that asking whether the NTB targets will be met is not asking the right question. As Dick Chason and I published almost a decade ago now, a focus on future targets far in the future may even be counterproductive. What we said was that the one thing we cannot afford in the fight against TB is complacency. The goals anchored decades in the future are helpful in charting a long-term course, but aggressive short-term goals will have the strongest influence on policy today. And so to my mind, the question is not, will we reach the NTB targets? The question is more, what can we be doing in the short term, and what targets are reasonable for us to be setting over the next few years that can help maximize the impact that we can have on TB worldwide? And so I would posit that we could reframe this as a different question. Specifically, can we achieve a TB step change with realistic interventions? And I don't want to take credit for this reframing. This is something that really has been done as part of a team effort led primarily by the three people pictured here in the bottom right: Surya Shrestha, Emily Kendall, and Nim Pathy. But what we have done is put together a model that that looks at a feasible but ambitious strategy, specifically one that would screen 70% of a population with an algorithm having realistic sensitivity, would treat TB infection assuming a realistic cascade such that only 30% of people would actually receive effective treatment after accounting for incomplete efficacy of the regimen, the fact that not everyone will accept treatment, the fact that even our tests for TB infection have imperfect sensitivity, etc. Household contact investigation, and then strengthening of the health system. So taking a suite of interventions that we believe to be feasible but ambitious, implementing these in a setting that is modeled after an emblematic Indian setting, and looking to see what might be achievable with this suite of interventions. And what we see on the left is the projected impact of this feasible but ambitious approach. So shown in the gray lines are our simulations of what the epidemic would look like in the absence of any intervention. So seeing already that we have a decline in TB incidence on the left and mortality on the right. And then in the magenta color are the simulations that then further account for the incorporation of this intervention. And so what we see in the two panels with the blue squares is a projected reduction in incidence of 43% at the end of 10 years. So comparing 2030, right here, 2030 to 2020, we see a reduction of 43% in incidence. This is plotted as a reduction here. So this is the baseline, and then the intervention shows about a 43% reduction in incidence at 10 years. Looking at mortality, we see an even larger impact, so 66% reduction in mortality. And then looking at absolute numbers in 10 years, for every million people, we could avert 7,800 cases and save 1,710 lives. So in summary, it is unlikely that we will eliminate TB by 2030. Doing so would require unrealistic scale up of current interventions as well as development of new ones that are unlikely to be implemented at scale in the next decade. However, I do think it's quite possible that we could rapidly achieve what we're calling a TB step change. So a 40% reduction in incidence, 2/3 reduction in mortality over 10 years with the implementation of feasible existing interventions. This step change would be rapid and would be sustained over time. And if we were to calculate out the total number of deaths were this sort of intervention to be implemented on a global scale, the 10-year impact on mortality would be greater than averting all confirmed COVID-19 deaths to date. So this is a big deal, even though we may not be ending the TB epidemic. This is certainly a goal worth aiming toward. And so I would argue that we need to set our sights on achieving success today, not focus solely on targets that are still a decade away, and not consider it a failure if we avert millions and millions of deaths, even if we don't necessarily achieve a target of TB elimination by 2030. I would like to close by acknowledging the exceptional team behind this, including at Hopkins, again, Priya Shetty and Emily Kendall, who led the model development and all analyses. Parastu, Kasai, and Todd Foho provided important technical assistance. NIMPathy at Imperial College London also provided important input. And then the team at the Clinton Health Access Initiative, Rebecca Chang, Roy Joseph, and Michael Campbell also contributed important intellectually to this model. I then want to close with a reminder that this can be done. So looking at data from Alaska from 1952 to 1970, after the implementation of a very similar campaign in which cases were aggressively found, active TB cases were treated, preventive therapy was delivered at scale, and health systems were strengthened. And what was seen was that in an 18-year period, TB incidence fell by over 90%, and TB mortality fell from 650 per 100,000, what would be considered an astronomical TB mortality today, to nothing. So just to say, this is achievable, and even if we do not eliminate TB by 2030, we can certainly have major impact on TB starting today. Thank you very much, and I look forward to answering questions at the end of the session.
Thank you very much for this invitation to speak at the ATS Union webinar on the possibility of TB elimination. I'm going to share to you on how to get from a higher to a lower TB incidence, and lessons from New York City, where I was the director during the 1990s. So in this presentation, I'll talk about what is low TB incidence and some of the low TB incidence countries that we have today in the world. And then WHO has actually developed a framework for how to address TB in low TB incidence countries. Then I'll talk about the example of New York City, where I called it walking the talk in New York City, and end with their TB control. The WHO has a strategic goal of ending tuberculosis by 2035, and they define a low incidence country as having less than 100 cases per million population. So for those of us who work in TB, that's the same as 10 per 100,000. There is a pre-elimination phase of less than 10 per million, or 1 per 100,000, or TB being eliminated as a public health problem of less than 1 case per million population. The SDG 3.3.2 has a target for tuberculosis, and it says, quote, end epidemic of TB in all countries. However, the target level is not defined. And let me put a caveat in this discussion. We often talk about high burden in our TB work, but high burden and high rates don't always track. In 2019, there were 54 countries that were low incidence TB countries. They were mostly in the America region and also in Euro, with a few in EMRO and WIPRO. The WHO has developed a guide in 2014 on 8 priority actions for low incidence TB countries. First, they talk about the need for political commitment, for the funding, to making sure that we have good services, and making sure that we leave nobody behind in terms of reaching the vulnerable, the hard to reach, and also migrants, and looking at cross-border issues because people travel from high incidence areas to lower ones. Making sure that we do the treatment of not only TB, but TB infection, and especially the issue of drug-resistant tuberculosis. Having a good surveillance and M&E system, research and new tools should be used. And also, even if you're in a country with a low incidence, we want to think of TB globally because of the travel issues. So let me move to the tale of the 4 I's, the tale of New York City, which is a high incidence city in a low incidence country. So there was the lack of infrastructure, immunosuppression in the form of HIV, a lack of infection control in the hospitals, and also immigration from high burden areas. And this was culminated in headlines like these in the newspapers, showing that TB was something to be feared. The US TB epidemic peaked in 1992, and New York City, which had 6.4% of the population, actually contributed more than double that, 14% of the US cases. The case rate, as you can see in the country, was almost at a low incidence place, 10.5 per 100,000, whereas in New York City it was almost 5 times higher. And there were areas of the city, notably Harlem, which I'll talk about in a second, which had case rates that rivaled many of the high burden countries. During this time, the US had steadily going down. However, in the 1970s, there was decreased TB funding. TB programs actually fell apart, federal, state, local. There was HIV, and the failure of the public health system. The then TB manager was found to be pounding on the desk. I can't do my job with 1 car and 1 outreach worker. An important study in New York City in 1991 showed the dire situation. Brudney and Dobkin, researching tuberculosis in New York City, looked at Harlem Hospital, the area that I noted had a very high case rate. They looked at 224 consecutive patients, and many of them had many medical and social problems, alcohol, crack cocaine. They were homeless or unstably housed. They discharged most of these people on treatment, and basically everyone failed treatment. Just over a quarter of them actually came back to the hospital within 12 months. And again, most of them were again lost to follow-up. The situation being so dire, the Centers for Disease Control and Prevention actually brought in their money and resources in the form of Tom Frieden and myself. And we worked for the next 3 years and showed that in between 1992 and 1994, there was a 21% decrease in tuberculosis and a greater than 20% decrease among Blacks, Hispanics, people living with HIV, and the homeless and MDR-TB. However, there was an increase in the elderly and the foreign-born, and the use of DOT increased from almost nothing to having almost 1,300 people on treatment under DOT. The conclusion was from this study was the decrease of ongoing spread was due to treatment completion, the use of DOT, and better infection control practices. The article was called Tuberculosis in New York City, Turning the Tide. However, I mentioned that the elderly and some immigrant communities were higher, and this left us with tide pools. And I wrote an article, What Will Be Left After the Tide is Turned? Between 1992 and 1998, non-US born cases in China, the Dominican Republic, Haiti, and Ecuador were prominent. There was the problem of completion, the poor completion rates for TB infection. This was a misunderstanding of what TB infection versus TB disease was, stigma in these communities, language barriers, fear of government, and also private doctors that many of these use for services gave inconsistent messages compared to the standard guidelines. They would go and say, oh, you don't need preventive therapy. We developed formative research and focus groups. We linked with the leaders and the advocates and the representatives of the community-based organizations. We interviewed experts around this topic on immigration, social issues, medical issues, and also developed some standardized questionnaires in the language that we were dealing with that were culture specific. Some of these even had to be given orally because of the pre-literacy of some of the clientele. And we gave food and transportation to some of these sites so the focus groups could be held. We also did education of medical providers. I made informal office visits to the doctors. We identified the doctors who were taking care of most of the people in these communities and to try and develop a public-private collaboration. And the deal I struck with them is said, look, I will give you free medications in exchange if you report your cases. However, you cannot charge your patients for these medications. These are free to them. I also held TB seminars and medical association meetings of these groups among the Chinese, the Dominicans, the Puerto Ricans, the Haitians. All of these are done at their convenience, weekend, evening hours when they didn't have to work. And then we developed many educational materials and translation, and also had a translation service that could basically deal with any language that came our way. In the public schools at this time, there were 110 languages spoken among the students. So languages were very important. You can see here, some of these came after this time, but you can see that there are many different languages and also educational materials in other languages. In terms of the impact of this, it was hard to get the actual impact of the TB infection and preventive therapy results because those were not reportable to the health department, but TB actually decreased in these targeted groups and continue today. So did we walk the talk? Remember that WHO had its priority actions from 2014. I was doing this work in the 1990s, and we did everything that was in the priority actions. We had a huge budget. We developed developed the first treatment manuals, reinvested in our clinics. We had multiple rounds with the hospitals to have them think tuberculosis. We reached the vulnerable and hard to reach, the homeless, the prisoners, the drug users, and we addressed the high burden immigrant communities, as I've just shown. Preventive treatment, it was a priority, as was the treatment of MDR-TB. In terms of surveillance and program monitoring evaluation, I personally reviewed every single patient in a group setting 4 times quarterly among our 5 boroughs, and we did a cohort review to see what our outcome rates were. We had a surveillance unit and a research unit which did operational research, and we were also part of clinical research consortia with academic settings and also the CDC. We thought globally, or actually globally thought about us. We hosted TB programs from Asia, Latin America, Europe, the former Soviet bloc countries, because the Soviet Union had collapsed in 1991, just prior to the situation in the United States, and provided TA to countries like Japan, Singapore, Spain, and the UK that were much more similar to what was going on in New York City. So in 2020, the results are there. New York City is no longer a high incidence area. It is in the low incidence category. It's at 5.4 per 100,000. In the United States, so that continues to be the case. The case rate for the country is 2.2 per 100,000. So New York City still is twice as high, but more than twice as high. And there was a decline from 2019, which I'll talk about in 1 second. 71% of the people with tuberculosis were non-US born, mainly coming from Mexico, the Philippine Islands, India, Vietnam, and China, very similar to what is going on in New York City. So to end, whether tuberculosis control or the COVID-19 effect, which has affected TB programs all around the world, we can see that between 2019 and 2020, TB declined by 20%. By any stretch of the imagination, that is a huge decline. There were surveys of the negative effects of COVID-19. For example, 60 to 72% said of the TB programs surveyed said they had a partial or high impact on staffing. 90% had to deploy their TB staff to COVID-19 activities. It affected the activities such as contact tracing, infection control, clinical care and treatment, isolation monitoring, patient interview times. It also affected their ability to garner resources, obtaining the medications, getting the personal protective equipment, finding housing for the people, hospital beds, isolation beds. But I think we need to really seize the day, carpe diem. There are positive effects that we're starting to learn from the COVID response. The whole issue of virtual monitoring using mobile apps and chest x-rays with artificial intelligence, novel diagnostic tests, self-testing, molecular testing, the care delivery with video DOT, electronic pill counters, bidirectional screening, and not having siloed programs. And also the innovation research, the amazing fact that we have a vaccine just after several months of work, the issue, and then also trying to do this in an open access and pooled technology way. So in summary, we need to continue our efforts if we're to reach the goal of ending tuberculosis. Thank you very much.
Thank you to Grania and to Danielle for inviting me to this series, and to Rhea and to Courtney for chairing. I hope we can have some provocative discussions at the end of this talk. I was asked to speak on the topic of stigma. Is it holding us back in TB elimination? And I guess the short answer would be yes. Alongside a multitude of other messy factors, stigma is most certainly holding us back. And I think anyone who's lived with TB treated a person with TB or even met somebody with TB can attest to this, can sense sort of the fear, the hesitation, the angst around TB that transcends the physical and cognitive impacts of the disease and somehow prevents us from achieving the goals we seek to sort of gain, as articulated in the NTB strategy and so many other declaratory documents. So I'm going to cover 4 things today. First is to outline sort of the main negative impacts of TB stigma very quickly, and then to discuss the drivers and manifestations of stigma. Third is to discuss what's been done so far to reduce stigma, and fourth, the unfinished stigma reduction agenda. There's been ample evidence on the detrimental effects of stigma on the TB care cascade, right from the onset of symptoms and diagnosis through to treatment completion and cure. The most common consequence has been sort of poor health seeking, which can lead to diagnostic delay, patient morbidity, and ultimately potentially patient mortality. Unchecked transmission as well is sort of one of the after effects of stigma. Stigma can also fuel poor quality of care, poor linkages to the appropriate treatments and supports, and non-disclosure is a very common consequence of stigma, compromising public health infection control efforts. TB stigma has been found to sort of disrupt patient social relationships, to trigger poor abidance with personal infection control measures. It can also undermine the patient-provider relationship by breaking trust, triggering non-adherence as well as non-completion of treatment. In the aftermath of many of these broken systems triggered by stigma, we can see a diminished quality of life, clinical and mental well-being, and reduced social status of people with TB, even after the stage in which they're treated and cured. So reducing stigma is very likely going to support TB elimination efforts because it's going to curtail many of these barriers that we see come up and emerge and sort of compromise the care cascade. But where does TB stigma come from? What does it look like? What does it feel like? I spent a large time in my research world sort of looking and working with communities in South Africa and India that have a high burden of TB and looking at sort of the drivers and manifestations and consequences of stigma. And as part of this work, as well as the work of others, we unpack and problematize these drivers. At its sort of most obvious level, TB stigma is connected to its clinical risk. We're dealing with a contagious disease which causes tangible morbidity and loss of life. So it's really not surprising that fear is a core component of why TB is stigmatized. At the underlying level, TB is a disease of inequity. Though the bacillus itself does not discriminate, the social prototype of TB is quite clear. It comes about more frequently in people who live or were born in poorer countries, who've immigrated or been forced to relocate elsewhere, people who live in overcrowded housing, including slums, prisons, shelters, or in large families, and people who are highly immunocompromised, notably on account of HIV, a disease which in and of itself carries a great deal of stigma. Ultimately, it's easier to stereotype, to devalue, and to stigmatize those members of our community, of my community. At a third level, notwithstanding these inequities, probably the most insidious types of stigmatization drivers is perpetuated by the systems in which we have to deal with the disease in the first place. Think about mandatory screening and treatment practices, notification and contact tracing practices, enforced treatment, quarantine and social isolation measures. These are all ideal disease control strategies, but if they're implemented without consideration to the inequities in which TB comes about, in which stigma comes about, then those same measures can seriously undermine patients' value, dignity, and even their rights, causing ultimately much further harm. Similarly, public health messaging around TB, the media, it can cast a nice spotlight on TB, which could translate to political action, to public action. Unfortunately, poorly developed media messaging can also be quite damaging, particularly when members of the TB community get framed as disease vectors and public fears and stereotypes are just sort of heightened. Now, stigma can surface in so many different ways. It can come about as an overt act of prejudice, for example, physical separation or distancing of patients, name calling, using words such as lazy, defaulter, or some other deviant label, disrupted relationships, or simply inaction, the absence of support where support would have normally been expected. Often this type of enacted stigma is not only encountered by patients, but also by their families, by caregivers, as well as health providers. But a lot of TB stigma is invisible. Something overt doesn't necessarily have to happen in order for stigma to come about. And research, in fact, shows that the anticipation or fear of discrimination can make people quite scared to disclose their diagnosis, scared to seek assistance from others, such as their family members, clinics and health facilities, or to stand up for themselves when they are being mistreated or encounter disparaging action. Research also shows that people with TB over time come to internalize others' negative attitudes and actions, feeling ashamed, guilty, and deserving of mistreatment, which over 6 months and longer for drug-resistant TB can result in a major loss of identity, confidence, and agency that can be quite hard to repair even after the disease has passed. Of note, stigma transcends space, whether it's encountered in our own heads, in our interactions with others, in our homes, and in the various physical and social structures that define our community. All of those forms of stigma have visible, tangible effects on people's engagement in TB care and can compromise elimination. So what efforts have been taken to reduce TB stigma, and what more can we do? Here's the voice of one former patient, the amazing Phumeza Tisili from South Africa, and I'd like to bring her here into the room with us.
I am Phumeza Tisili, an ex-direct TB survivor from South Africa. I think people stigmatize what they do not know or have less information about it, especially when it comes to TB. There is a need for TB awareness in our communities. Well, I noticed when I started sharing my story, it was easier for others to come share their stories too. This broke down the stigma as people were coming forward. So this normalized that having TB is nothing to be ashamed of, and that anyone can actually get TB. So I think for now, especially in our communities, TB awareness is very much needed. Thank you.
Thank you, Phumeza. Thank you for sharing that. This leads me to talk about the types of interventions that have shown success in stigma reduction when implemented in select high incidence communities. And most of these draw on exactly the types of ideas that Phumeza has just shared, knowledge and attitude shaping interventions that involve the delivery of accurate TB education and information, and promoting positive images about people with TB to other patients, to community members, and to healthcare providers. However, if the messaging is poorly worded, there is a risk of compounding stigma, for example, when there's undue focus on TB risk versus TB recovery. There's also been several psychosocial support interventions implemented with people living with TB, including counseling situations and counseling encounters, family engagement encounters, and peer support groups, as Phumeza has just mentioned. All of these types of interventions have shown effectiveness in reducing anticipated stigma among people with TB and community members, as well as reducing internal stigma among people with TB using a number of qualitative and quantitative methods. The effect on the overt acts of stigma or enacted stigma, however, are not known. There have also been a handful of studies that have sought to empower people with TB by engaging them in activities where they can express themselves, share negative as well as positive encounters, and develop communities of support, such as through photo voice. While these have not been evaluated, the research suggests that they likely do reduce internal stigma by building resilience to social and medical adversity. Unfortunately, these interventions only address some of the known drivers of TB stigma that we know, as denoted by the green boxes. They've possibly had some positive effects on social messaging, social acceptability about TB. They've possibly raised awareness about the effects and the curability of TB. They've possibly had some address to inequity, not necessarily by combating the social determinants of illness per se, but rather by creating spaces for patients. For patient engagement and for developing a sense of solidarity and community action. Then there have been a multitude of community efforts and biomedical advancements that have likely helped to reduce the stigmatization of people with TB in some settings by combating the things that we know are the building blocks of TB stigma. And although these efforts have not been formally evaluated, they are most likely to have had effect because of the pathways that I'll just share. This would include developing shorter, tolerable treatment regimens which can cut morbidity, death, and the side effects of treatment, most notably for drug-resistant TB. delivering treatment education and counseling that is happening in select settings during this process of TB treatment. This allows people to better understand the recovery process and normalize what they're going through. Investing in occupational safety to protect healthcare workers can also dispel some of the fear of contagion. Enabling material supports for people with TB, again, in various select settings, could mitigate stigma by including access to social grants, enabling access to safer new drugs, food security, and other forms of financial assistance, and inviting people with TB to join policy and program level discussions, for example, through community advisory boards. Then there have been efforts to sort of reject the use of stigmatizing terms to describe people with TB and to actually integrate patient values and preferences into policy level decisions, for example, through the WHO's grade process. And many of these efforts are in some form or the other encapsulated under the WHO's End TB strategy. Now, these efforts are beginning to address a much bigger range of stigma drivers, but you can see that several drivers remain missed, calling for investment into bolder efforts, particularly efforts that can incorporate structural change within TB programs and address to some of the wider social determinants of the disease, particularly the inequities in which not only TB, but the stigma about TB comes about. So I want to discuss three things in this regard to guide the way forward. The first, let's consider where we're likely to get the greatest bang for our buck with regards to investing in TB stigma reduction. Some colleagues in South Africa have recently published this paper which showed that stigma, particularly anticipated stigma to TB, is greatest among people who are at the cusp of entering the TB care cascade, that is, people with presumptive TB, much more so than people in the general community or people who've been diagnosed are already on treatment. This suggests that stigma reduction efforts would be most crucial and most impactful at the stage of symptom onset and presentation through to the stage of TB screening and testing. And this idea links back to operational TB research, which demonstrates huge losses in the care cascade happening exactly here before patients are formally diagnosed and before they're placed on TB treatment. Second, we can learn from what's happening within HIV social movements, as well as current movements to destigmatize COVID-19. I alert you to two papers among so many others that have been published in this topic. The first is a very recent expert review article, which compiles evidence on stigma mitigation from many different disease outbreaks, inspired, of course, by the most recent one. And the second is an older, briefer commentary about how HIV activism can translate in TB. Now, these papers offer a lot of useful insight about the actions that could be taken to help reduce stigma, and I summarize 5 of the points here. First is to involve patients and communities in research, program, and policy decisions. These are our allies. They're not threats. They're not vectors. Second, to use destigmatizing language and to engage the media to transform the narrative. Let's disconnect social demographic characteristics of patients from disease rates. So we start to dispel some of the myths, we start to correct some of the rumors and break down some of the inequities. Let's lobby for political action. Third, let's deliver equity and patient-oriented care. Institute choice wherever possible. Nobody is doing DOT anyways, so why not advertise self-administered treatment and use it as a way to empower patients? Institute virtual monitoring in acceptable and equitable ways. Deliver some form of differentiated service delivery frameworks, particularly for stable patients. Abide by the basic principles of privacy and confidentiality during the testing, treatment, and contact investigation stages of TB management. Enable access to safer drugs, to newer drugs, to rapid tests, and address the needs of the most vulnerable. Use science to empower and enable affected people, right? Let's focus on cure, not just TB risk. Let's tell people when they're non-infectious, not just when they are contagious. Let's think about the physical distancing aspect of social distancing, right? Social distancing is just a terrible term. We do not want to promote social and mental isolation. What we do want to promote is during the early stages of treatment, physical distancing. And let's make sure to end that period when the patient is no longer infectious. Address individual as well as structural drivers of stigma, right? Education and awareness are excellent, but they're limited. Ultimately, we need legal, economic, and social protections to be put into place so that we can combat and tackle some of those underlying social inequities that drive TB and TB stigma. So all of this would afford us opportunities to address so many of the drivers of TB stigma. And I feel confident that if we were to sort of adopt some of these, put our money and invest in some of these structural changes, there is hope. We can address all of the drivers of TB stigma. The final point I'd like to make is as we work towards TB stigma reduction, let's not get stuck in what I term an evidence conundrum. We already have so much evidence that stigma impacts the TB care cascade. There have been ample studies published, ample reviews performed. We know stigma is bad. We know it's damaging TB elimination. The next set of studies have got to be intervention focused. We have to move towards translational and action-oriented stigma work. We also have so many terrific tools to measure, to assess stigma. We should use them wherever possible, particularly for single component interventions where effects can be more easily attributed to the intervention. And the results can help us to measure success or failure and lobby for intervention scale up in appropriate ways. But this is the sort of crux of it. Stigma mitigation requires a structural, multi-pronged effort. And often those are exactly the types of approaches that are very difficult to evaluate. That cannot be an excuse to detract us from investing in those efforts, promoting them, implementing them to scale, because these are rooted in fundamental principles of social justice, of human rights, and social responsibility. The stigma reduction approach in TB is entirely in line with the goals of the NTB strategy. So let's not delay further because stigma is holding us back, and addressing the drivers of stigma will most certainly strengthen the pace of TB elimination. I'll leave you with just a few resources. All of them are open access and clickable. I hope you'll have access to the slides while you're watching the webinar. And I mentioned many of these papers in previous slides. I also alert you to some of the tools that have been developed. Some of them I've been involved with, some of them very close colleagues who I would say are experts in the field, greater than I am. I thank you so much sincerely, very sincerely for your time and for your sort of ear, and I'd be happy to take questions, or you can email me anytime. Thank you so much.
Hi, my name is Salmaan Keshavjee, and I want to thank our hosts for inviting me to present today. I'm going to talk to you about what does TB elimination look like in 2021. In order to do that, we have to think about why TB elimination appears so far. And I think the reason is because there has been a glacial progress to achieve elimination over the last few years. So if we look at it, the data from 2018 from the WHO tells us that there's still about 3 million undiagnosed patients every year. There are still about 4,000 plus people dying every day. And we still have less than 20% of the people with drug-resistant TB being cured. So we have a major problem in finding people, treating people, and of course, preventing transmission of TB in communities and families. And if you look at the data, you can see that drug-sensitive TB has declined a very small amount per year between 2006 and 2016, 1.3% per annum. MDR TB has declined around 2% per annum in that same period. XDR TB has increased 8% per annum. So the decline in TB incidence is very slow, and at this rate, we will not meet our global goals. So the update from the WHO, the most recent update in 2020, shows us that of our SDG targets, we wanted a 20% reduction in TB between 2015 and 2020. By the end of 2019, we achieved 9%. Same thing with reduction in TB deaths. We achieved 14% of 35%. And as a percentage of people facing catastrophic costs, we wanted 0%, and it was down by 49%, which is definitely a move in the right direction. As far as the UN high-level meeting on TB, where countries came together for to identify treatment targets, we wanted to treat 40 million people between 2018 and 2022. We're now in 2021, but as we can see from the WHO's data, in 2018 and 2019, we had achieved less than half of that goal. And same thing with TB preventive treatment. Only 6.3 million out of the goal of 30 million had been reached by the end of 2019. So that's 1/5 of the goal. So really, far from achieving the goals that we had set out. Now, COVID, of course, has had a huge impact in the period after 2020. Globally, policy and program officers reported in a survey conducted by the Stop TB Partnership that there have been significant drops in TB notification. So 70% of officers from the Global Fund reported a decrease in the number of people receiving treatment. And we see this in data from the WHO's Global TB Report for 2020, which showed that trends in monthly notification in 4 high TB burden countries dropped. It picked up in some, but in others, like Indonesia and South Africa, you can see that it didn't pick up. Indonesia a little bit, and South Africa less. So the global trends in the TB incidence rate and the absolute number of TB deaths compared with those required to achieve the 2020 and 2025 milestones are not in sync. So we are not on the right trajectory. So the question then is TB elimination possible? And the answer is yes. Just like before 2020, just like before 2021, TB elimination can be achieved using the search, treat, prevent, epidemic control strategy that has existed since the early 1960s. So I know that you know this, but I want to just go through it. The first part is searching for people with TB disease and infection. We know from the early 20th century that X-rays are a great way to screen people. They were a critical tool for finding active cases and stopping transmission in TB. Jonathan Golub has written a great review of this, and we know that this was one of the tools that was used in the United States and Europe, in many rich countries, to bring down rates of TB. It not only contributed to finding new cases, but even without antibiotics, it led to decreased mortality because of early case detection and sending people to sanatoria. And we have tools to confirm TB disease. We have modern versions of the X-ray machine. Here you see one in Pakistan. We have things like the machines. We've got the Hain test, the genetic test, and we've got, of course, Gene Expert. And there's other tests that I don't have pictures of here. But we have the tools to confirm TB disease and drug susceptibility. We also have tools to confirm TB infection. We have interferon gamma release assays. We have skin tests. So we actually have the tools. We have just not deployed them en masse. So we have not implemented a comprehensive search strategy for TB disease and infection globally. And so I think for that alone, we cannot say that elimination is impossible because we haven't done what's needed to get to elimination. So secondly, treating TB disease correctly. I think we've done better in this area, but we've known since the 1950s that early treatment with the correct medicines given as a multi-drug regimen in the shortest period of time stops transmission of both drug-sensitive and drug-resistant strains of TB rapidly. We've known that. And yet, when we look at our progress, we have not been able, because we haven't been able to find people, we haven't been able to treat them. The TB target for kids between 2018 and 2022 was 3.5 million. We only achieved 1/3 of them by the end of 2019. We wanted to find 1.5 million people with MDR-TB. We achieved 1/5 of that. And for for kids with drug-resistant TB, we wanted to find 115,000. We found 9,000. So we have not achieved the goals that we have set, and we definitely have the tools to treat people. We now have short course regimens for drug-sensitive TB. So a major gap is getting this out to people. All oral regimens for DR-TB. Many countries are not using this as widespread programmatic use. So that's a major gap. We still do not give patients supports that include foods and cash transfers, even though there's data that shows that works. So there are major biological and social gaps to getting the treatment right. So when we say, is elimination possible? Yes, but we have not implemented a comprehensive treat strategy for all forms of TB disease. We have missed the mark on that. And then the other area where we've missed the mark is prevent TB infection from becoming active disease, and of course, prevent transmission of TB. And here we know that treating TB infection that has not yet progressed to clinically apparent disease is an essential part of stopping transmission. We know this from data from Alaska. George Comstock and colleagues showed in Alaska, they randomized communities to treatment with isoniazid prophylaxis for people who had been exposed to TB, to people who had TB, and communities that didn't get isoniazid preventive therapy. And what they showed is that if you did a comprehensive approach with active case finding, treatment of all forms of disease, and treatment of TB infection, you could bring transmission in households and communities down to 0. And they did this by looking at the annual risk of TB infection among children 1 to 3 years old. So you could bring it down to 0, and that tells you that this can actually be achieved even in a difficult situation like Alaska. And of course, this makes a lot of sense, right? Because if we've been focusing on people who are smear positive. We know that with X-ray you can find more people, those that are sputum smear negative. Some people have extrapulmonary TB. And that's important for our case finding so we can prevent transmission, especially with the people who have X-ray positive and microscopy positive TB. But those that are TB infected, we know that 8 to 10% of them will move on to active infection within 1 to 2 years. So it is really, really important to find those people and treat them with TB preventive treatment. And so that is why we have to do that. And people say, oh, this is such a huge thing. No, if you think of it 1 to 2 years after exposure, that means there's 20 to 30 million contacts a year that we should be finding, and they should be receiving treatment. And why this is important is because the idea that these bugs are latent and not doing anything is very old-fashioned. We know that there's a spectrum between infected and disease, and people are releasing mycobacterium at different rates based on that spectrum. And there's models of granuloma evolution that support that show that there's something that may be fully what we would consider latent, but then there's these kind of percolators and then the different rates of disease as disease progresses. And if, we've kind of said, okay, maybe we should do it for drug-sensitive TB, but in a meta-analysis of 25 studies, 7.8% of household contacts of MDR TB patients also developed TB, and most of it, as predicted, occurred within 3 years. 47.2% of contacts had TB infection. So even thinking about it for MDR TB. So you start to say, well, we need to have preventive therapy for drug-resistant TB. We have that. We have moxifloxacin is used in some places. Drug-sensitive TB, we have that. We have 3-HP, we have 1-HP, and we have a variety of other regimens. And even now, places like Vladimir are doing preventive therapy for XDR TB using bedaquiline therapy. So, we have the therapies. Have we delivered it? The answer is no. For people living with HIV, we've done better. We wanted to achieve 6 million people by 2022. We achieved 88% of that goal. Household contacts less than 5 years old, we wanted to get to 4 million people. In the first 2 years of this period, we only achieved 20% of that goal, 1/5. Household contacts of people over 5 years old, that's really important because that's where the kids get it. They get it from the older contacts. That's where people with HIV get it. They get it from the other contacts that have active TB and are coughing up bugs. We targeted 20 million people as a global community between 2018 and 2022, and we achieved less than 1% of that. So we achieved 1/5 of our goal by the end of 2019. So can we, and we have tools, right? We have tools to stop, to do preventive therapy. We have tools to stop transmission in hospitals. That's a different type of prevention. We've got upper room UV lighting that we've used for years. We've got respirators that health staff should have. There's a shortage of that right now because of COVID, but even before COVID, people weren't using this. We have negative pressure ventilation, which we've known about for years. This is a hospital in Lesotho that has it. But these are things that we could do that we haven't done. So when we say, oh, is it impossible to achieve TB elimination? Well, we haven't implemented a comprehensive prevent strategy for TB disease and infection globally. So we can't say that. We've missed the mark on that as well. So we know what search, treat, and prevent can achieve, right? Faster progress towards elimination. This is what happened in Alaska when they did improved case finding and community-based active case finding, treatment of all forms of TB, and treatment of TB infection. You see that rates drop markedly. Same thing in New York when they had their epidemic at the end of the 1980s, even though they had a high rate of HIV and many people were homeless. Because of community-based active case finding, treatment of all forms of TB, treatment of TB infection, you saw the rates drop markedly. Same thing in Tomsk in the Russian Federation, amongst other places. You saw the rates drop by 55%. So, and we've even seen this in Karachi. Karachi rolled out the X-ray vans just like New York and London and Melbourne and other places had. But this time they used artificial intelligence and digital X-rays. And guess what? In the area where they had an intervention, which is the red line, versus the area where there was no intervention, they saw a 25 to 30% decrease in rates of TB. So they found more cases and those numbers went down. And this was in a system that was not closed. It was in a system that was just 2 million out of Karachi's 20 million plus. So really, really impressive outcomes if you use the search, treat, and prevent strategy. So the question is, what should we be prioritizing in order to achieve TB elimination? Well, the first thing is we have to ensure that all countries implement the comprehensive and simultaneous search, treat, prevent strategy that has worked. So search actively and test properly, treat effectively and support people through treatment, and prevent exposure, using the infection control things we talked about, and treat exposure with preventive treatment. That is critical. So that's what we have to do. Every project should include this. It cannot be optional. Every project has to include this. More importantly, the Global Fund has been dismal when it comes to TB. Many people have gotten on treatment, of course, and everyone's grateful for that. But it has not kept up with the UN HLM goals. Donor countries like the UN donor countries like the US need to ensure that the Global Fund only funds programs that includes all components of the search, treat, and prevent strategy. The Global Fund should not be funding substandard programs that don't have all the parts of the comprehensive approach. Every program should be moving towards the comprehensive approach. We have known this since the 1960s. So here we are 60 years later, and we have an international agency funded by the citizens of the world that is funding subpar programs. We have to change that. That has to change. And then we have to focus our research on search, treat, and prevent. And that means at the deeply biological level and at the social level. So what are the drivers of infection and progression to disease in people? Are there better ways to diagnose infection? Are there different biological markers? Are there different markers that indicate different stages of disease? How do we optimize X-ray technology? How do we link up with existing diagnostics in the private sector? How do we screen for other diseases? How do we incentivize case finding? When you think of treat, are there new agents, therapeutic vaccines, immunomodulators, or other inflammatory agents that can be used to shorten treatment, anti-inflammatory agents that can be used to shorten treatment and improve outcomes? Should we be using different methods to deliver therapy to people, like depot patches, etc., depot shots and patches? Should we be rotating empirical first-line regimens? Very rarely in medicine do people use the same therapy year after year after year. Should we be integrating surgery into treatment algorithms? Are there behavioral economic tools we should be using, like conditional cash transfers? And the same thing with prevent. Are there better ways to develop preventive therapy, to identify people who need preventive therapy and deliver the medicines for it? And are there better therapies using immunomodulators or therapeutic vaccines? And really thinking about context of drug-resistant TB. So let me end there by saying, yes, we can achieve elimination. TB elimination in 2021 should look like it should have looked for the last 60 years. We should have search, we should have treat, we should have prevent. It should be comprehensive, it should be simultaneous, and we should really be pushing it through all the mechanisms that we have globally. So thank you very much. I appreciate that.
Hello, my name is Priya Shetty. I'm an assistant professor at the University of California, San Francisco in the Division of Pulmonary and Critical Care Medicine and the Center for Tuberculosis. I've also recently taken on a role as the chair for the Global Health Policy and Advocacy Working Group of the American Thoracic Society. I'm very honored to have been invited to participate in today's discussion on TB elimination, a topic very important to me and my work as an early career investigator. The topic I'll be speaking on today is entitled All Hands on Deck, Leveraging Lessons from the COVID-19 to Eliminate TB. I have no disclosures. When I was first asked to provide my perspective on this important topic, it was to provide the perspective of what early career investigators can do to further TB elimination and our goals in that regard. But I have to admit, it was quite challenging for me to imagine that kind of discussion without thinking about my own experiences and those of many colleagues around the world who are developing and accelerating their careers and their research portfolios in the context of COVID-19. And so I'm providing a slightly different twist on this topic by describing how we might as a community modernize in some ways TB elimination agendas and research towards those agenda goals using lessons learned from the pandemic response. And in particular, I'm hoping to start the discussion on thinking of how we might enhance our approaches to methods, to devising research questions, and to engaging investigators, particularly investigators that are either often not established or crossover investigators from other fields. So first, the numbers. None of these are new to you. In 2020, COVID-19 overtook tuberculosis as the top infectious disease cause of mortality worldwide. Globally, we know that about 10 million people developed TB in 2019, and 1.4 million died from this preventable, diagnosable, treatable, curable disease. Unfortunately, post-pandemic, we'll likely see an increase in those numbers given significant health service disruptions around the world. I'd also just like to put into context that while there are estimates of somewhere between 3 and 4 million deaths from COVID-19 worldwide thus far, tuberculosis has killed almost 1.5 million to 2 million people for the last several years and is an ongoing epidemic. Unfortunately, progress has slowed in achieving the United Nations General Assembly end TB targets, primarily because of these service disruptions. But maybe also it wouldn't have been as clear that we would be able to achieve our targets given previous rates of decline in incidence and other goals. Unfortunately, the drivers of tuberculosis, the social and structural determinants of health that are most typically linked to poverty, such as undernutrition, poor food security, poor access to healthcare services, poor housing, ventilation, are now exacerbated by COVID-19. And so really there's a huge need to address those determinants now. So for me, and for many of my colleagues who are early career investigators, the elephant in the room is COVID-19. And instead of thinking of how disruptive it's been, I'm hoping we can paint a silver lining in some ways, or to learn lessons from having this elephant in the room and seeing what shelter we can gain from it in the TB world and how it can help us in our quest for TB elimination. So first, I'd like to focus on some methods, and Dr. Dowdy gave an excellent talk on modeling. And in this regard, I think the emphasis on modeling and data science as a way forward for TB elimination is an important one. And you see the lessons we've learned from COVID-19 in terms of the use of modeling and data science shouldn't be ignored. For the first time ever, we've seen heads of state, heads of government around the world showing and describing the results of modeling and data analytics studies in press conferences, meant to provide the basis for rapid policy decisions and to provide the grounding for political commitments. The importance that modeling and data science had in driving early decisions about the pandemic response, even in the face of uncertainty, shouldn't be ignored. And here you see that, in high impact journals like Morbidity Mortality Weekly Report, MMWR, put out by the US Centers for Disease Control and Prevention, taking a look at the modeling of future cases of COVID-19 hospitalizations and deaths by vaccination rates and non-pharmaceutical interventions. And on the left, you see, sorry for the poor graphics, but image pulled from the Institute for Health IHME metrics and evaluation in Seattle that provided grounding for geographically focused modeling on expected cases, deaths, hospitalizations from COVID-19, and how over time with additional data and in the face of new interventions, those estimates can change. In some ways, I'd like to just draw attention to how not only the use of modeling and data science as a really important approach in driving policy for COVID-19 could be translated to tuberculosis and the achievement of our TB elimination goals, but the real-time change in some of these estimates over time with the advent of interventions as a monitoring tool to see how countries and states in the US, for example, are doing in their pandemic control might be something that could be, again, utilized for monitoring of the tuberculosis epidemic. And the last thing I'll say about modeling and data science is that from an early career investigator perspective, it's a really exciting field. Many scientists new to tuberculosis, but with experience in data science, mathematics, statistics, and infectious disease modeling from other infectious diseases have a lot to offer the TB space in this regard. And as a recruitment and retention strategy, it's a dynamic field. And Dr. Dowdy, I'm sure, can say more about that. The second area of research I'd like to draw your attention to is disparities research. For many investigators worldwide, COVID-19 has shown the impact of disparities very quickly in the pandemic and in the pandemic response. These disparities include all of the socioeconomic indicators that we typically think of, and also integrate the use of place-based vulnerability indices or other indices called area-based socioeconomic measures to provide very granular, targeted approaches to understanding where COVID was striking and what interventions did to mitigate disparities in those places. In light of this, taking our research around TB elimination to integrate more concretely disparities is an important one. It not only can highlight hotspots for disease, but also provide some sense of how inequity and socioeconomic indicators are affecting our disease outcomes. What you see here is just a snapshot of some work that I've been involved with and leading at the California Department of Public Health over the last year, where as a TB researcher, I was repurposed to be a COVID researcher. And what you see is on the left panel, the map of the state of California with measurements and metrics that reflect the reopening strategy for the state based on metrics, including notably a health equity metric designed to make sure that things like test positivity rate and the lowest resource setting in the state should not exceed those of the most resource settings within the state. In those places where that equity metric was not met, that jurisdiction was not allowed to reopen economically as much as their neighbors. So in this way, real-time data can demonstrate how disparities evolve over time based on testing case rates and mortality shown here for COVID, but similar things can be done for tuberculosis in high incidence settings. And the other avenue of importance, I think, for the disparities research piece is how quickly it translates into policy. And so because of the linkage that was clearly demonstrated across the world between low socioeconomic status and vulnerability with COVID, COVID incidence and transmission and poor outcomes, policymakers were very quick to identify solutions that targeted socioeconomic barriers in their COVID response. Finally, to integrate and bring to the table a more diverse array of researchers, focus on disparities research can really enable early career investigators from fields such as behavioral research and sciences, from social epidemiology, from geography, et cetera, to the table to address problems of tuberculosis. Right now, the iron is hot for addressing socioeconomic determinants of poor disease and health, poor disease outcomes and poor health. And tuberculosis as a field and community should really take advantage of this. The next thing I'll describe, and I am certainly not an expert in this field, are the use of adaptive trials and high quality observational data to inform decision-making and response. I think in the last 5 years, tuberculosis has done, as a community, has done a really great job of integrating novel clinical trial approaches to developing short course drug regimens. However, it's been slow to get to this stage. What we have seen in the COVID pandemic is the repeated and quick use of adaptive trial designs to develop treatments that can be stood up and deployed for people at risk of poor outcomes quickly and efficiently across the world. There's also often a hesitation to use observational data to support decision-making, and rightly so in most cases. But in the lessons that we've learned from COVID-19, if we're treating a disease as an emergency, which has occasionally been a term used for TB, then we should be more inclined to integrate high quality observational data into our decision-making in a more holistic way. So now I'll turn my attention to describing the investigators, and particularly early career investigators, and how the work that group of scientists can do can really support TB elimination and the next generation of TB researchers. Earlier career investigators, unfortunately, have suffered a lot during the pandemic, mostly because of funding disruptions, increased clinical duties. Many of us spent much more time at the bedside than at the bench during the pandemic, because the skill sets that we have in terms of clinical care were required at much higher scale than previously at any time in our careers. And finally, competing family obligations and household obligations took people away from their science and their research, with disproportionate effect on early career investigators. Notably, that's not necessarily something that's only driven by the pandemic. The pandemic highlighted disparities in research as well. Early career investigators are often more likely to have to take on clinical service obligations more so than their senior counterparts. They often suffer from limited funding pools because of lack of attention to their early career status. And finally, just based on their age and demographics, often have more family and household obligations to attend to in their off hours. In the context of COVID, several funding agencies have adapted new ways of dealing with this challenge, including, for example, providing that National Institutes of Health is providing extensions for early career scientists whose career trajectories have been significantly impacted by COVID-19 in the form of either no-cost extensions or, in some cases, additional year of funding to support gaps in funding because of the pandemic. And for those who are watching this and haven't taken advantage of some of those funding extensions, encourage you to talk to your program officers. Disparities in terms of career development and age are not the only ones that have been highlighted in the pandemic. The other group that's been disproportionately affected have been women. Again, because of increased teaching, clinical, and administrative duties that typically fall on women, the COVID pandemic has increased demands on time to meet those duties during a high need for both clinical time and administrative time, and to think about ways to pivot in-person teaching to remote teaching quickly and adapt curricula. In addition, it's been well documented that women scientists have disproportionate family and household obligations, even as compared to male scientists in the same field and at the same rank. And finally, it's also been well documented that COVID-19 had reduced productivity in this demographic group. And the figure you see on the right is from a recent Nature paper that showed that even the amount of preprints in scientific journals and scientific preprint servers during the pandemic response, has deteriorated rapidly. It was never great to begin with. Somewhere between 50 and 40% of articles and preprints were led by first author female investigators. But during the early pandemic period, that dropped from 40% to 20% or less during April 2020. And it's hard to imagine that it's increased since then. So is this something that's just related to the pandemic, or is this something more systemic? And because of just the baseline and increased teaching, clinical, and administrative duties that women investigators face, they're more vulnerable to these sorts of disruptions. Why is that important for tuberculosis elimination? And why should we be thinking about supporting, as a TB community, supporting policies to improve retention for female investigators? Well, it's because of the very nature of tuberculosis, where we see that the research portfolios of underrepresented minorities, including women, often attend to social and structural determinants of health, often attend to the healthcare of low-resourced communities, and they often utilize research approaches that are not typical or traditional. And those are all recipes for success in terms of thinking about out-of-the-box solutions to get us to TB elimination. There has been some data that policies to improve retention for investigators that integrate sex and gender can be effective. And here I would suggest that the TB community stand behind these policies and ask that grant applications, funders, funding support, et cetera, should consider gender and sex in their rubric for scoring proposals. I'd also like to draw your attention to a group of scientists that we're calling citizen scientists, who have made a huge impact on COVID-19 in a very short amount of time. And as a TB community, we would be wise to think of ways to better integrate them in addition to our civil society partners. Citizen scientists are really members of the community who are without formal training in a specific health science, but who can contribute. They can run the spectrum up of being frontline data collection staff, meaning turning on exposure notification application on their phones, excuse me, or utilizing their mobility and position tracking devices and allowing access to those for those who are using mobility as a measurement, for example, in the COVID pandemic, of the reproductive number, the effective reproductive number. There are also ways for other non-health science trained investigators to get involved with TB elimination and TB research by using open data sources to, kind of mess around with the data and see what comes of it. The picture from a Twitter account of Yuen is an example of just this type of citizen scientist. Yuen is a data scientist with no formal health training, who during the COVID pandemic developed probably the best performing statistical models of COVID incidence, hospitalizations, and mortality of any group or any group of researchers worldwide. And the way that he was able to do this is by taking advantage of open data where available to parameterize and inform his modeling. The reason I think this is an important area for us in TB elimination to consider is that there are a lot of people who are highly skilled in a variety of disciplines who are not exactly TB researchers, but who, with the appropriate enticements and availability of data, could do a lot, as they have with the COVID response. And finally, what we can learn from citizen scientists and their engagement with COVID-19 related activities is that maintaining science communication publicly has a really important effect on generating smart, skilled, and scientifically well-versed communities that can then support activities towards TB elimination. So my summary is kind of short and hopefully sweet. A colleague and mentor in California has said this to me early in the pandemic, when we noted how quickly political commitments, funding, and research were moving towards addressing COVID-19. And she said, let's not ever take no for an answer. And I think that's true. The figure on the left shows that is taken from the US government's federal budget tracking website and describes the amount of funding that's been allocated, dispersed, committed, and allowed for the pandemic response. And we see that over $7 trillion US has gone towards COVID response thus far, and rightly so, based on its scale. The federal budget for tuberculosis is far more limited. And while we do a lot with what we have, it just shows that where there is political will and commitment, a lot more resource can be leveraged to address a problem of global health, such as TB. And finally, on the right, and I am not an immunologist or a vaccine expert by any means, but from a layperson's perspective, you could imagine looking at this figure taken from Nature in 2020, describing the time it takes to identify a pathogen and have a functioning, effective vaccine licensed. And you see the red as the start of the year in which the pathogen was linked to disease, and the blue the year in which the US vaccine was licensed. And the dot for SARS-CoV-2 is overlapping, blue and red. And while there are many challenges in establishing a tuberculosis vaccine, it is clear that where there is a will, there is a way. And many investigators from a variety of fields have used technology developed for other diseases to support the development of SARS-CoV-2 vaccines. I think one of the most unsung stories of the pandemic has been the advent of a new malaria vaccine based on mRNA technology. And so as an investigator interested in those novel approaches, and in some ways filling the tall order of trying to represent earlier career investigators in a variety of fields, let's not take no for an answer. Thanks very much for your time.
Thanks so much, Priya. I think that was a bunch of extremely interesting presentations. I know I learned a lot, and I hope you all did too. I think I really found what Priya said very interesting, because my first question is actually on vaccines, and I want to direct this to David, because I feel like, David, you're an epidemiologist, and I noticed in your presentation you are not too optimistic about eliminating TB by 2030, and I hope you have a more optimistic answer for this question. But given the fact that we saw with Ebola and with COVID how quickly we developed vaccines, and I have a bone to pick with these two diseases. I was like, how quickly did that happen, right? And why are we struggling so much with TB? I mean, do you think we can develop a new TB vaccine in the next couple of years?
Great. Well, thanks, Rhea. I am not sure I'm the perfect person to answer this. And I don't want to underestimate the immunological challenges of dealing with TB as a bacterium that can cause latent infection, etc. But I would harken back to what Priya just said in her presentation, and also what Salmaan was getting to. I mean, in some ways, where there's a will, there's a way, right? We have seen an unprecedented outpouring of financial and political support for developing COVID vaccines, and as Priya just showed, we were able to, as a society, come together and develop a vaccine in about a year, right? And we've been working on finding an effective TB vaccine for in adults for decades now, and the most obvious difference, again, taking some of the immunology aside, but the most obvious difference is the relative amount of not just financial support, but also political support and general interest. And I think that if we're able to, and we should be thinking of the pandemic as an opportunity to get people interested and engaged in infectious disease control more broadly, and recognize that that TB kills, again, well over 1 million people a year. If we're able to, and we'll do so for the foreseeable future unless we are able to implement more aggressive interventions. So if we can get people interested in this, then funding and political support and scientific breakthroughs will follow. So there's no reason we can't do this for TB as well.
So it's a problem with commitment. So where there's a will, there's a way, right, Priya?
That's also like, those are strong words, but I'll say it. Sure, why not? I mean, I think it's an interesting perspective for those of us who are, I'm a pulmonologist and a TB clinician and researcher. And last April, I pivoted, like many of us did, and used those same skills, right, towards COVID, because that's where the need was. And so I think it's a little bit on us as a community to reflect on the need of TB patients everywhere and those at risk for TB, and say that you are as equally important. The big thing that we're not saying out loud, and I'll just get on my soapbox for one moment before passing off the baton, is that to me, the reason just many of us, I think, have this perspective that COVID was able to leverage such political will and commitment so quickly is because it was perceived to affect everyone equally. That is not the case. It didn't affect everyone equally. And in TB, we already knew that. TB doesn't affect everyone equally. And so I think ultimately, if we as a community are allowing political will and commitments to fall by the wayside, we're saying that poor people in under-resourced settings are not as important, is frankly what we're saying. And so if we're not comfortable with saying that, then I think we should do something about it and try to leverage all the tools we have. And my talk was not the perfect, I think, way to reflect on some of those topics, but I think many people are interested in supporting in whatever way they can. And so being more open and inclusive about the problem solvers we include and how those problems can be solved might get us there more quickly.
Thanks, Priya. I think that inequality has been one of the themes that's cut through, I think, all of these presentations. Paula talked about New York City. Salmaan and David both mentioned the examples of Alaska. These are two places that had high TB burdens, but they were in a high-income country. And they were able to rapidly drive down TB rates with aggressive investment. And Salmaan makes the case that, while a vaccine would be great, we do actually have a lot of the tools we need. But as you, Priya, and you, Amrita, pointed out, because TB affects marginalized populations, those investments are not necessarily forthcoming. So I think my question to everybody is, how do we dismantle the inequality in the system? So whether this is inequality of policies, where high burden or poor countries have different actual policies in place that are not equipping them to address the pandemic, or whether it's about inequality in resource streams that are available to places. What do you guys think about how we start making a change in that?
Well, Courtney, if I may just weigh in on that, one of the things that we've seen, we've known that we have this policy, we've had this comprehensive approach since the 1960s that's worked, right? And so the question is, why haven't other people done it? And there's been an active policy not to do it. So preventive therapy, Comstock presented his data to the WHO expert committee in 1964, and it was deemed too difficult for poor countries. Again, presented in 1974 after multi-year follow-up, more than a decade of follow-up, deemed too difficult. 1982 to the Union and the WHO Joint Committee, they said that it was too complicated for poor countries. 1993, not included in DOTS. We just saw a document that Paula showed us for 2014, which basically said that rich countries should do X and poor countries should do Y. And then March 4th, 2018, the policy changed that poor countries can do preventive therapy if they want, if they're able. So there's never been a push. The Global Fund funds projects that don't include preventive therapy of context. Basically, it ensures that 1/10 of them are going to go into disease and maybe die. And yet we all say, oh, the Global Fund's doing such a great job. if the Global Fund didn't fund maternal to child transmission of HIV, would we be like, oh my God, that's so great? Because their excuse is, well, the country coordinating mechanism should ask for it. What if they don't ask for maternal to child transmission? Wouldn't somebody tell them, guys, guess what? This is really important. But no, that doesn't happen with TB. So I think that there's been dismal policy level pushes to make this happen. And then on the ground, because there hasn't been a policy push for 60 years, the ground game isn't what's required. And so people, everyone say, well, the country don't ask for this. Well, you can't ask for what you don't want. If I have a knee problem and you say, do you want a CT scan or an MRI? I'm gonna be like, I don't know, right? So somebody has to say, you need to, these are the things that we need to get rid of TB. David showed us that the WHO modeled it in 2009. So if you forget 60 years and you say, wow, we've at least had 12 years of it, Paula showed us that New York did it in the late 80s, early 90s. So if you say we knew it 60 years ago, we knew it 30 years ago, we knew it 12 years ago, it is just a policy failure, and it's colonialism. It's a double standard. People in countries that are poor, mostly who are brown, get care X, and people in countries that are rich, who are low incidence, should get care Y. And I think all of us should be outraged and say, no, we're not doing that anymore. That's not what we do. And we should be leaning on the Global Fund board. We should be leaning on the funders, the US government and other people, and say, do not fund substandard projects. That is wrong.
And Salmaan, thanks for that. And actually on that note, I want to just move the conversation to Amrita, because it was interesting to note, Amrita, that you worked extensively in India and South Africa. And I feel like, you'd be the best person to answer this question. And compliments on including a community person in your talk. I love that. Thank you for that. So just I wanna know what you think. Do you think that countries like India would really wake up to taking more precautions to airborne diseases like TB post-COVID? You think they get it now that it's time to do something about this?
Well, India is interesting, but yeah, I sure hope they wake up. But I think they'll wake up because, who's getting infected now in India? Yeah, there's tons and tons of poorer people, but tons and tons of rich people too. And the world just wakes up, right? When people when people unfortunately that look like, that have clout, that have power, get infected. That's what happened with HIV. That's what's happening with COVID. It doesn't mean the most atrocious pieces of this epidemic or of the pandemic are coming alive in the most marginalized groups of people. But the only reason that they're benefiting from anything that's happening is because COVID has also affected the most wealthy, the most affluent, the most powerful people.
Yeah, and rightly so, because till now no one's actually paid attention to TB because it primarily affects the developing countries. So, I mean, suddenly when it affects the developed countries, everyone just wakes up and says, okay, let's do something about that.
Yeah, I think we have to wake up to this. And we all talk about equality and equity, but I think the TB community, the TB scientists, the TB policymakers and funders really have to think about an equity-oriented lens when they fund projects, when they think about where investments have to go. It's got to be equity oriented. I mean, people who've heard Paul Farmer speak, I'm sure they've heard about the socialization of scarcity. We're okay, if some people back there in another world don't get the same equipment, the same resources, the same tools that we sitting here in North America might be getting. That's damning. That would never work. If you are a white man that is the demographic of TB, do you think we'd still be here?
No, we won't.
I think in New York, we saw the city, the community as a whole, and everybody was being affected in that sense at that time. So this is where the political will came into being. So in a way, I didn't have to fight because everyone realized it was an emergency. So this is what drove the equation forward. And I was really struck by what David said in his talk. He said, instead of looking at the long term, look at make aggressive short-term goals. And this is exactly what we did. In 3 years, we got it down by 20%. And this is it's almost 25 years ago when we didn't have half the tools that we have now. So it can be done. And people say, well, you had the money. But yeah, you can have money, you can use it poorly. We had money and we used it wisely. So I think that that's a really important lesson. I hadn't looked at my New York experience for years until this opportunity came up to put together this talk. And I said, wow, we really did, we were really able to accomplish something that now is very relevant for today.
Thank you for your work, Paula. I think that was amazing.
Yeah, so just jumping off all of these really useful comments about, like, what I'm hearing from many people is that there's the perception of who the disease affects, and there's the reality of who the disease affects. And the political will and the investment are as much about the perception as the reality. And so with COVID, is there anything like that the TB community can take from the COVID experience to move forward, to restructure, rebrand, whatever, to try to break down some of this lack of political will that's being caused by this us and them distinction? Because as you've pointed out for COVID, there actually are disparities. There's huge disparities, but it's not perceived as that. And Paula, what you just said, in New York, it was perceived as affecting the whole community. In fact, it affected portions of the community much worse than other portions, but that wasn't the way it was that it was perceived. It was still perceived as a public health emergency. So how do we achieve that for TB moving forward?
I mean, I'll jump in. I think part of it is the way we present our data. And in the COVID pandemic, it really quickly, dashboards were stood up that demonstrated real-time disease and how it affected people by race, ethnicity, by socioeconomic status, by geography, et cetera. And I think that those dashboards were extremely helpful in keeping these questions about, equity at the forefront of the discussion and monitoring equity. That shame and fear are very important tools sometimes for politicians. And I think having to see that data all the time drives a lot of decision making. So I do think there's some things that we can do as a community for TB to demonstrate our data in a way that emphasizes these issues around equity and the interconnectedness that we all have globally. The second thing I'll just also reflect on is the openness of data. And it's something that there's always a challenge with public health and researchers and maintaining privacy and that sort of thing. But in order to solve the problem quickly, many communities and public health organizations, jurisdictions opened their COVID data much more than they've opened any data before for the community to conduct research in real time and design policy options that were feasible to implement. And so I think as a TB community, we can ask for more open data and to ask for it more in a more granular way that allows us to demonstrate those disparities to drive the policy discussion.
Yeah, I'll chime in a little bit to say I do think that the data are important. I think that we need a multi-pronged approach that relies not just on data, but also on a personal sort of connection. And here, I applaud both of you, Rhea and Amrita, for bringing in the stories of TB survivors. I feel like what really drove the pandemic response early on, or in addition to some of the data elements that Priya is talking about, were like images of hospitals overflowing, right? And doctors saying like, we're overwhelmed, we can't manage this. For people to actually feel like this is an issue that matters to me and matters to people that I care about. I don't think we do a good enough job of trying to raise that sort of awareness. I don't want to pretend to be an expert in this, but I feel like this is a big part of what's lacking, is that the people who hold the political and purse strings just don't think that TB is a problem, right? And and they're wrong. But we have to find ways to make it feel more of a personal issue to people. I think before we're going to see the mountains move.
But David, can I push you on that? Because, you know, Paula pointed out that I agree that we need more money and we need more political buy-in. But Paula pointed out that in New York, they got money and they used it well. They used it comprehensively. So we have money going to many projects around the world that is not being used comprehensively. And that's been going on for decades. So, you know, even with our current money, we could get a better bang for the buck. And then we could say, yes, we need more. But instead, we just say we need more. And if I were a policymaker, I would say, you've achieved a 1% drop per year for X billion dollars. Why would I give you more? Like, what can you do? What are you going to do differently? And I guess that's the question we haven't answered as a community. We have all these things that say, oh, yes, of course, now we should do, say, preventive therapy or active case finding. But it's not implemented on the ground. We don't see any results. Like Pakistan and a few other places, but it's a handful.
And rightly so, Salmaan, because even just from my own experience, I mean, I had access to resources, I had access to doctors, but the doctors didn't know what they were doing. I mean, they were just treating me wrong. So I think it's about a question of quality of care and not just about money.
Did they screen your family, Rhea? Did they screen your family?
No, no.
I mean, that's just like crazy.
Yeah.
Right?
No, they even lost my reports. That said, I had TB. So no, Salmaan, just I mean, just coming out. I mean, writing on that topic, I was just it just really hits me to the bone when I hear about latent TB, and you know, I don't understand why the world is not talking about latent TB. And when you see the numbers, it's very scary, because I mean, in India they say anywhere between 50 to 85% of people have latent TB, and that's like a ticking time bomb. And I'm really happy to see you cover that in your presentation. So I'm just wondering, what do you think needs to be done to increase evaluation and treatment for latent TB in high burden countries like India?
Well, the US CDC has done a great thing. They've stopped calling it latent TB and has really moved towards calling it TB infection, which it is, right? And now that we understand that there are these like percolating people that don't appear to have active disease but periodically release bugs, we understand better that, oh, okay, you know, we need to treat TB infection because it's a range between infection and very active disease that we can pick up. Now, you know, when people throw out these numbers and say, oh, 1 billion or 2 billion people have TB infection, that kind of makes your eyes glaze over, because you're like, oh, wow, you know, how are we going to do that? But if somebody says what is the truth, which is that people who are newly exposed to TB and get TB infection go on to 1/10 of them, or almost 1/10 of them go on to have active disease in the 2 years after exposure, then suddenly you're like, oh, because there's 10 million new cases of TB per year. We only find 7 of them, but let's work with the number 10, like pretend we find everybody. Let's say they all have 1 or 2 contacts who are positive, then you would treat 20 million people for TB infection, right? Not 1 billion, not 2 billion, 20 million. And people say, oh my God, but how will we treat them? Well, the therapies are the same as the treatment for TB. It includes the same drugs. And you're allegedly giving care to the person in the household. Why would you not give care to the 2 people that are beside them? So even the delivery part is possible for that group. Now people say, oh, but what about migrants? What about this? We are doing nothing right now. So let's forget like these very hard to reach groups for a minute and start with household case detection, household case finding, and household contacts at a minimum. Then go out onto community, etc. And of course, it's going to depend on the location. So what we have to do is actually make it part of the algorithm of care, right? If I have lice and you know that it's transmissible in the household through furniture and people touching my hair, whatever, you wouldn't say, Salmaan, let's treat you. And then we'll just leave everyone else. You'd say, oh, you need to do this and we need to treat, you know, or scabies or any other social disease that passes between people. This obviously happens to be airborne in the case of TB, but if it's passing between people, you would not just stop there. So we've suspended medicine for TB. We've suspended how we deal with social diseases. We've suspended how we deal with antibiotics. We use the same ones for 40 years. And then we say, oh, there's drug resistance. Well, every hospital changes their antibiotics every 3 or 4 or 5 years. So we know this, but we've suspended science for TB. And I guess what I'm saying is, let's stop suspending science with the money we have, and then we can ask for more money. But asking for more money while we've suspended science doesn't seem to make sense.
And if I ever get lice, I think I know who to go to, which doctor I need to visit. Thanks, Salmaan.
Can I say something about this preventing the eyes glazing over response that Salmaan is referring to? And I think this is what happened in New York City. It was seen as an emergency, so it was a local response. And it wasn't like, I mean, we were concerned, people started to be concerned around the world, and that's why people started to come to us, right? And we hosted people from everywhere trying to learn what they could take back to their own communities for their own local response. So I think that's what's important, is to have the politicians or the community, whatever, look to what's going on locally. That will help. It's little steps to help that, because that eyes glazing over. I mean, yeah, when I think about $1 billion or whatever, it's just like too much. But when you think about what I can do in my own community, then it feels like reachable.
I think we can go through one more question, just in the interest of time. I know we're really over time, and just one question that came in from the audience regarding USAID and the Global Fund claim that they don't have the funds to implement the comprehensive approach to TB. Is this true or false? Anyone? Let's have a dig at the Global Fund.
No, this isn't even a dig. They are right. Like, if you were to do this comprehensively everywhere, there is not enough money. So is the answer to do it uncomprehensively everywhere, right? So let's do substandard treatment because we don't have enough money. And again, that did not happen with HIV. That has not happened with malaria. Nobody says, oh, we're going to give you some medicines, but we're not going to give you nets because it just costs too much. Or like, nobody does that. They say, this is what you need. You need these 5 things, and we're going to do it. And that's what you have in your programs. And with HIV, people say, oh, no, it's too complicated to find mothers who are about to deliver. We'd have to have people knowing who's going to deliver when. It's way too complicated. We're not going to give maternal to child transmission prophylaxis. They don't do that. They figure it out. And so I guess what I would say to the Global Fund and to the WHO, you are right that you don't have enough money to launch a program where you screen everyone in the communities using, let's say, X-ray and Gene Expert and let's say some sort of infection test. And that you are right that it'll cost more for medicines. You are right that you will need more staffing. But the answer is to create a platform in a number of places, phase 1 projects, and then grow those projects. And as they grow, you would go to your donors and say, guess what? Everywhere we've done these phase 1 projects, we're seeing drops of 10 to 20%. We need another $3 or $4 billion to expand it. Going to your donors and saying, we're going to do the same stuff we've done for 40 years, that achieves almost nothing, but a tiny bit, which is great, and we need more money for that. It's not a compelling argument. So I think that they need to say, we want to have a pilot. I even hate to use the word pilot. We need to have a phase 1 project in every setting where we work, with the aim that those phase 1 projects will be expanded. And then we will ask for more money to do that.
Success breeds success.
Yeah. Look how successful
at the local, at the local level, Paula, as you pointed out. I mean, there's been economic modeling showing that TB programs pay for themselves in the increased economic productivity of the people who aren't getting TB and aren't dying prematurely and aren't getting their families sick. So, the net amount of money isn't like one big pot that we currently don't have. It's an entire approach and a way to think about how to leverage the resources we do have that's totally lacking.
Yeah.
So I know that we've already gone over our scheduled time, and I think a lot of us have other meetings and stuff on the hour. So I just wanted to thank everybody for an excellent session with your presentations and the discussion. As a reminder to the attendees, the recording will be made available and posted on the ATS website. And the next webinar in the series will review the role of prevention in TB elimination. And I just like to give a call out. There's a specific talk on vaccines in that session, which I know a lot of people have been submitting questions to in the pre-registration system. So thank you for attending. Stay safe, stay healthy. Thank you, everybody.
Bye, everybody.
Bye, everyone.
Thanks for organizing us.
Take care. Bye.